Okay, so just like when we were talking about the head, we had different landmarks. So the thorax being a much bigger area, there's very specific landmarks that you're going to use like when you report an abnormality. So just be aware of the anterior and posterior, but the reference lines, these, and I have a diagram, are the most helpful in describing where you are on the thorax. So right here, hold on, let's go right here. Okay, so right down the middle on the front is always going to be the mid-sternal line. Then if you go to the arm, you have the mid-axillary line. In front of that is the anterior axillary line and the posterior axillary line. So that's how you differentiate all your lateral parts. And then if you go to the middle of your clavicle and straight down, which is kind of like the nipple line, we call it the midclavicular line, or some people call it the nipple line. If you flip them around, your down the middle is your vertebral line, and then through your scapula is your scapular line. Now, that's not necessarily anything you need to know for like a quiz. I'm just letting you know that if you want to describe something right here, you would say like, you know, fourth rib, right midclavicular line. Otherwise, how the hell are you going to describe where everything is, right? Let me go back here. Be aware kind of just like landmark wise, okay, you know that we've got 12 ribs because this area is what?
The floating rib section?
Well, but what did we talk about?
Costal
vertebral angle, right? Because we know that that's at the T12. Likewise, you can see, and I don't get my skeleton in here, but you can see that the first rib is actually clear up here. So that means that we have lung tissue that goes all the way up. So when we're listening to lungs, you're going to see nurses just go like this. No, we have lung tissue all the way up here to all the way down where your T12 is. So, and I'll show you more later, but when you listen, you're going to be listening along this whole area here, okay? Okay, so the lung borders, we call the apex of the lungs up here, right underneath the shoulders, where those first and second ribs are. That's the apex. When we get to the heart, you'll see that the apex of the heart is the bottom. But in lung speak, the apex is the top of the lungs, base of the lungs. Actually, the bases of your lungs are posterior. Your lungs don't come all the way down in the front. They drop and then come around posteriorly. The right lung has 3 lobes. The left lung has 2. Just remember the word right has 5 letters, as does the word 3. It's longer, so it has more lobes. Left lung just has 2 lobes. The trachea and bronchial tree, so we all know where the trachea is because we just checked off. When the trachea branches off into each lung, that's your bronchial tree. So it attaches directly to the trachea. The pleura is the lining of the lung on the outside. And there's a negative pressure where the lining of the lung sticks to the thoracic cavity, and that's what keeps our lungs inflated, is this negative pressure. So have any of you heard of like a pleural friction rub? Have you heard of it?
Yeah.
Okay.
It's like leather.
Yeah, it's like leather. What a pleural friction rub is when the lining of your lung is rubbing against the thoracic cavity. It's the outside of the lung, okay? So you'll hear people that have pleuritis, which is an inflammation in the lining of the lung. It's really painful. It's like a sharp stabbing pain. Okay. So this is what I'm talking about. When you're looking at the front of the lungs, you can see they stop, right here at the ribs, and then they come down lower posteriorly. So when I'm telling you, you need to listen in the bases of the lungs, that means you need to come around posterior and listen to the bases back here, okay? Here's the thyroid cartilage that we talked about during checkoff. And then it comes directly down into the trachea and then your right and left bronchus, okay? So that's just some basic anatomy. This is the mechanics of respiration. very pathophysi. So basically you inhale, what do we breathe? About 19 or 20% oxygen in. It goes down to our lungs, our blood flow picks it up, and then the carbon dioxide dumps back in, and then we breathe out the carbon dioxide. It's kind of amazing if you think about how many times in a day or a week and a month we do that. Like, we totally rely on our body to keep us going just doing that. So you can read through developmental competence. I'm not really overly concerned about it. Do you know pregnant women, because they've got bigger blood flow, they have more oxygen need. So that's why pregnant women are often breathless, because they have a 40% need in tidal volume, but they don't necessarily get all that air in. So pregnant women are going to be more breathless just because of that. There's all sorts of issues with infants and children in the lungs. Surfactant, do you guys know what surfactant is? Have you heard of that?
That would be like the surface on, like, maybe like a layer on the surface of
Kind
something?
of. What it is it's a mucousy layer that keeps our lungs moist, basically. If we didn't have surfactant, our lungs would crackle and dry up, and they wouldn't be able to expand. So all surfactant is like it's something that we produce, but they also give it to premature babies to speed up their lung function, to increase lung maturity. So yeah, without surfactant, our lungs wouldn't be stretchy and kind of moist down in there, which sounds awesome, I know. So I kind of revamped this because there was like just 2 lines. So TB has largely declined, but sometimes in certain countries, foreign-born countries, ethnic groups, there still are higher incidences. Consequently, the treatment for TB is 6 months of antibiotics, minimum. So it's a long, I mean, we at least have antibiotics for it, but it's a long treatment. Asthma has increased in all racial and ethnic groups due to genetics and environmental factors, but African American and Hispanic children still have the highest incidence of asthma, and therefore the highest amount of ER visits still right now. There's new research that shows that African Americans and Africans develop COPD earlier, even if they smoke less, because of a genetic, something in the gene. So somebody who is African American and is 35 and only smokes a half pack a day will still develop COPD earlier than people who are Caucasian or Asian. Women with COPD, when they get it, they tend to decline faster and much earlier. Currently, the data we have shows that the smoking rates are the highest in the Native American population and lowest in the Asian populations. Hispanic, Caucasian, and African American are right there, like right in the middle. And then there's one genetic lung disease called alpha-1 antitrypsin. I don't know if anyone has ever heard of that. It's the only lung disease that's genetic and will give you COPD without smoking. But so it's most common in Northern European white descendants. Yeah. So every culture, every genetic background has the propensity for some type of lung disease.
Do we have a TB vaccine? We don't have a TB vaccine in the U.S., right?
We don't. It is available in other places. Does anybody here that was born somewhere else have a TB vaccine? You did? Did you guys get the TB vaccine? Mm-hmm. So I would imagine if we had it endemic here, we'd probably get one.
Okay.
Did you guys get it in Africa or get it when you came here?
Both.
Both? Okay. So, thing about the lungs, it's a bigger area, but the assessment is very straightforward. Do you have a cough? Do you have shortness of breath? Chest pain. Is your chest pain worse with deep breathing, or is it present without deep breathing? You need to ask that. What's your history of respiratory infections? By that, we're talking about pneumonia, chronic bronchitis, and of course now COVID. What's your smoking history? Don't just say, do you currently smoke? Because they might say, well, no, but but I've smoked for 30 years prior to this or whatever. So just say, tell me about your smoking history. No judgment, just tell me about it. Environmental exposure. People who have worked in welding, in chemical plants, people who live along the river, there's certain lung conditions that go along with those environmental. What did you say?
Oh, I said mines.
Mines, yeah.
What people in the fields?
Yeah, out in the fields. Yeah,
the pesticides.
people who work around like chickens are at higher risk for histoplasmosis because of the feces. So there's lots of like little subgroups.
Also for smoking, whenever we ask it at the hospital, do you smoke? If they say no, then the immediate follow-up is, did you ever smoke?
That's a very good way to do it too. Yeah, if you want to be more direct rather than just say, tell me about your smoking history. Yeah, that's a good way of putting that. Part of your review of systems, the subjective part, is you need to ask about if they've had a TB skin test, if they are long-term smokers, COPDers, have you had a chest x-ray recently? Have you had pneumonia and influenza vaccines? And now, of course, we can add COVID vaccines to that for some populations. Okay. So the objective data, mostly it is, consists of listening to the lungs. But there's certain things that you're going to do on your checkoff that are more than just listening. So when you look at the shape and configuration of the chest cavity, normally, if you were looking at me from the top, I should be 2 parts here to 1 part here. Does that make sense? The ratio. So the transverse ratio, I should be 2 parts here to 1 part for the A to P. So somebody say who's barrel chested and they're round instead of oval, their ratio would be 1:1. Does that make sense?
Mm-hmm.
So I think I've got a diagram I'll show you because it's hard to understand what I'm saying without that. Symmetric expansion. Let's see, come here, Kaylee. When you do symmetric expansion, you're looking to see if both lungs inflate the same. So you put your hands here on their back and you ask them to take a deep breath. And you want to make sure that the hands move out. You'll report that as symmetrical bilateral expansion. Okay, thank you. Tactile fremitus. I don't know if anybody has read ahead on their respiratory chapters yet. Probably not. But tactile fremitus is when I'm going to put my hands on your back and you're going to say 99, 99, 99. Okay, the reason why is if I have clear lung tissue with no masses, no infection, it's going to feel one way. If I feel my hand over what is like a consolidation, like a pneumonia or a mass, the sound is more concentrated because it has something to travel through. So basically with tactile fremitus, you're just wanting to make sure that as you move down their back, the vibrations are the same. So when you do your checkoff, I'll ask him, and you can either use your palms or you can use the lateral part of your hand. I want him to say 99.
99. 99. 99.
Like that, okay? That's tactile fremitus. Percussion. When we're percussing lung tissue, most of the time you should have resonance and hyperresonance. What causes that? Why is it like that?
Because of the pressure?
But what's underneath that makes it sound resonant or echoey?
Depending on if your lungs are filled with air or not.
Right. So resonance and hyperresonance are where you should, if you're percussing, you should hear mostly echoey air-filled places. If you're percussing over a rib, then you're going to hit dull. You will not need to do this for checkoff. I just want you to know that you should be hearing mostly resonance and hyperresonance if you're percussing over a lung. When you listen to breath sounds, you absolutely must put your stethoscope on the skin, okay? During checkoff, if you don't do that or don't verbalize it, you will get counted off for it because it's that important. You can miss really important things by listening over close. The only caveat is if you've got somebody with a super hairy chest, you can wet it, or if they have a very thin shirt and you listen very carefully, you can go over. Otherwise, if you put your stethoscope on a hairy chest, it is very much just like you really can't
Probably
hear.
the same as putting it over clothes, or just about.
So yeah, putting it on the clothes is not ideal, but at least you can hear, like you don't get all the scratchy noise. Okay. Abnormal breath sounds are called adventitious. That word is adventitious. It is not advantageous, which a lot of people lapse into, but it's adventitious. So when you're doing your lung or your checkoff and you listen, and I'll show you how to do the 8 places and the 8 places, you'll report, you can either say no wheezes, crackles, rhonchi, or you'll say no adventitious sounds noted. So adventitious just means abnormal lung sounds. Okay.
Crackling or what else?
Wheezing, crackling, rhonchi, we'll go over all that. And I'm gonna, if audio works in here, I've got some lung sounds to listen to. Okay, does anybody know what incentive spirometry is? We're
Yes.
still on objective data. Okay, tell me about
They
this.
blow into that.
Do they blow?
Or no, they suck.
Right,
And
right.
They inhale.
They inhale.
And it has a little thing in it to see how far
Mhm.
it goes up.
And what's the purpose of incentive spirometry?
Seeing your max lung capacity.
So it measures that, but what is its primary function?
Isn't it to help? Because I know a lot of people did it after they have surgery.
Right, and so because what are we worried about?
Pneumonia
Right.
settling and all.
So what we do with incentive spirometry is
Deep breathe.
you inhale deeply and the air goes down and opens up all of those little airways down in the bases of your lungs, because after surgery those tend to collapse, and when those little bitty airways collapse, then you get pneumonia, or you're higher risk for pneumonia.
How do you say it? Atelectasis?
And that's what that is.
Okay.
Yeah. So atelectasis is when the little bitty air pouches at the very end of your airways, they collapse. So we use incentive spirometry to help prevent or treat atelectasis. So when we say lung collapse, we don't mean the big lung. We're talking about the tiny little airways, the alveoli at the end of your lungs. Okay, so any questions on IS or atelectasis or anything like that? You can't hear atelectasis necessarily.
So
What's the 6 minute?
atelectasis is when those collapse.
Uh-huh.
Okay.
So the little alveoli at the very end,
Uh-huh.
those collapse.
Okay.
And we use incentive spirometry to try to reinflate them so you get better ventilation.
And that's the same reason when you have like an immobile patient that you turn and make them deep breathe.
Exactly. That's the exact reason, because they're not using all of their airway. And when we don't use that for several days, those tend to just kind of collapse down on each other. So
What is the 6 minute walk test? Is you just have them walk for 6 minutes?
yeah,
and
so
then-
you're basically, what a lot of times what they'll do is they'll put an O2 sat monitor on,
Okay.
they'll put a pulse oximeter on, and they'll have them walk for
Oh,
5 or 6
that's
minutes.
okay.
Yeah.
Sorry, I've done this at work. I've never heard it called the 6 minute walk.
I
test.
haven't either. I've
I've
heard
never
it
done it for 6
called, I think
minutes.
it's like
We call it
ambulation.
a walking pulse ox.
Walking pulse ox, right.
Very
So you're like walking them around with the little thing on their finger, and you're watching to see if their oxygen drops and their pulse goes way up. So I've not even seen it called a 6 minute walk test either, but that's what it is. And then is everybody familiar with a pulse oximeter? You know what that is? That's the thing you put on your finger and it measures your O2 saturation, doesn't it? Okay. Here's my little dude. Here is what I'm talking about, the shape of the AP to thorax. So this is somebody, if we were looking down on him, he's like got kyphosis,
Yeah, I was gonna
right?
say, got some kyphosis
He's got some
going on.
kyphosis and he's kind of barrel chested. So his one, it's almost 1-to-1 from here to here to here to here is 1-to-1. Or
So
like,
the front is up.
So for you and
Oh, that's the
I,
sternum. Is that?
I'll show
That's
you.
a spine in the back you're looking at.
Yeah, so this is the spine. So you and I should be more like this. So
Okay.
we'd be 2 parts this way to 1 part this way ratio. Somebody who's like barrel chested or COPD or kyphosis is going to have a more of a round. So what you'll say, it's an inspection. So you'll go like this during the checkoff and you'll kind of check and you'll say her AP to transverse ratio is 2 to 1. Or transverse to AP is 1 to 2, is how you will say that. So, but the whole point is to show you that these different problems affect the way that your lungs can expand. What is this?
Scoliosis.
Yeah.
Scoliosis.
So look at the reduced lung function on this one side just because of the shape of the thorax.
So how would
And
you
that's
report
their-
that one then?
This one?
Yeah.
So because of the scoliosis, I mean, you might say, you know, left side is adequate, right side is
Okay.
reduced,
Yeah.
whatever, yeah.
And
They
that's
just-
the side with more lobes too.
And at the right?
Yeah.
Yeah, so it's a little bit bigger almost. The left lung only has 2 lobes because the liver needs to fit up under there. Is that right? No, other way around. Wait. No, your liver's on your right, y'all. Come on, why didn't you correct me?
With a better
So then
Oh,
is it
no,
your
it's too much
pancreas
caffeine.
that's in the way and that's why there's only 2
So the
lobes on the left
spleen,
side?
it's the spleen, pancreas, top lobe of the liver, and the stomach
Okay.
all have to fit
Okay.
over here. Whereas
Yeah.
this, on this side, it's just the liver. Yeah. So pectus excavatum. So that's when. Have you ever seen somebody and their breastbone is really sunken in? So think about when you excavate, you dig in. So pectus excavatum is a sunken chest, and then pectus peritoneum is when it pops way out like more like this. It comes out, and that's called pigeon chest. And it doesn't have any significance other than if they have lung function problems. And then we've already talked about scoliosis and kyphosis. Okay, so the average breathing rate for an adult should be about 10 to 20. 10 to 20, 10 to 22, right around in there. When they say occasional sigh, you know how you'll just be breathing and then you'll just feel like the need to take a deep breath?
Mhm.
That's what that is. It's just because your body is saying, hey, you've been sitting in one position for a long time, let's get some more oxygen. The term for when your breathing is greater than 20 breaths per minute is tachypnea. So we don't typically say, oh, they're breathing really fast. You'd say patient has tachypnea, you know, and that's a pretty fast rate. That's somebody who's hyperventilating. You know, that's greater, that's 22, 24 or greater breaths per minute. Slow breathing under 10 is called bradypnea, okay? So you don't say, oh, their breathing is slow. You say they have bradypnea. Chain Stokes breathing. Has anybody heard of this?
Yeah.
That's when you have that that neurological.
Yeah, usually it's not a good
Issues.
sign. If somebody is Chain Stokes breathing, there's a ventilation problem. They'll breathe irregular for a while and then they might return to normal, but then they're not ventilating, so they start breathing weird again. You don't need to know it for a quiz. I'm just letting you know.
It's on path.
So, chronic obstructive breathing. So, what does COPD stand for?
Yeah.
Chronic obstructive pulmonary disease. Okay, and COPD is actually an umbrella term for emphysema, asthma, and chronic bronchitis. So a lot of people who have emphysema, they'll just say they have COPD. Technically, though, they have emphysema. So COPD just means they can inhale air just fine, but they can't exhale it. You'll see them, like, you'll
The
see them
first
take a
lift.
normal breath in and then they'll be like, so because they have obstruction, they can't get the air back out. And the 3 conditions that cause that type of breathing are emphysema, asthma, and chronic bronchitis. So you'll hear those interchangeably, but COPD is kind of just an umbrella term, okay?
Isn't there a breathing test they do for that too? For exhalation and see
So
if you're
there's,
making
you
like
can,
a certain
you
tidal
can,
volume or whatever?
yeah, there's a breathing test that shows how fast you can expel air in 1 second, called an FEV1. So has anybody ever done one of those?
Yeah, we used
Where
to
you
do them on the
breathe
fire
out
department
as
every
hard
year.
and fast as you can, and it measures how much air you can exhale in 1 second.
What was bleh.
Yeah,
Is
it would
a
be
test
for
like that?
COPD.
Okay.
We use it for COPD, we use it for asthma, or any of those things.
Right.
Yeah, yep.
That test sucks.
Yeah, it'll run you out of
It's-
air. You
it's-
get a little
and
lightheaded.
It's
in a minute.
uncomfortable.
Okay, this is not something you need for checkoffs, but this will be on your quiz, and this is usually where people tend to struggle, so I added this slide. You have 3 different areas that produce 3 different type of lung sounds. You have bronchial sounds, you have bronchiovesicular sounds, and vesicular. These are normal. These are not abnormal findings. This is what you should be hearing, okay? So, where's your bronchus? Right
Here.
Right here. So you're only going to hear bronchial sounds only in the front in this area right here. Okay? So if somebody says, "Can you hear bronchial sounds in the back?" No, you cannot. Bronchiovesicular is where the bronchial tubes start to branch out. So bronchiovesicular, you're going to hear kind of in the middle here and in the middle on the back. Okay? Vesicular sounds refers to the normal sounds you hear out in the lung fields. So your vesicular sounds are going to be out here in the periphery of your lung tissue, okay? So
On front and back.
front and back. The only bronchial are the only sounds that you cannot hear from the back because they're directly over the trachea and bronchus. I would know this well for the quiz. And that's why there was no slide in here for it, and I just feel like most of us are visual, and if you can visualize, like, it makes it a lot easier to understand.
For bronchiovesicular, you said it was here,
Uh-huh.
down the middle.
Yeah, so
Okay.
think about vesicular as like the peripheral lung sound.
Okay.
So bronchiovesicular is where bronchus meets, like
Got it.
branches out. Okay, so any questions on this? And there's a lot about it in like your chapters and stuff, but I just wanted to bring it up. You will not need to name any of this for checkoff.
Okay.
This is just quiz material, okay? Okay, so that tactile fremitus I was talking about, 99, 99, 99. So increased tactile fremitus means that there's an increase in density of the lung tissue. So a tumor, pneumonia, something where the sound can travel through better, you have increased tactile fremitus. Usually you don't see decreased tactile fremitus. We're more concerned with what's growing there that shouldn't be there. I'm not too concerned about rhonchi and pleural friction fremitus, just kind of read about it. But this is the one that you'll do on your checkoff. Okay. So I tried to make a better slide for the adventitious lung sounds, but I also, if I can get it to work, have audio for this after we're done, because it gets confusing. So, and I'm not going to get real, like there's some rhonchi wheezes and there's sibilant wheezes. For the most part, most wheezes are high-pitched and squeaking. You guys have probably heard wheezing, right?
Mm-hmm.
What condition do we associate that with? Smokers and
Asthma.
asthma, yeah. So wheezes are when you've got mucus or a little bit of an obstruction in those little airways. And those little airways make little squeaking noises, okay? So let's start at the top. So fine crackles are like a popping. So think about maybe when someone pops like the, you know what I'm talking about?
Yeah.
That's
packaging stuff.
Yeah, the packaging stuff. That's kind of what your fine crackles are. Coarse crackles are more of a bubbling or gurgling. So somebody who has maybe fluid in their lungs from CHF or a pleural effusion, it's going to be more of kind of a bubbly noise. And yes, it takes a lot of practice to know what you're hearing and be able to name it. I mean, in real life, what's most important is that if you hear something that shouldn't be there, you need to report it either way to the doctor, okay? You may not be able to say, oh, there's a fine crackle there, but a coarse crackle there. You may just say they're crackles, okay? And that's okay. So, atelectasis is hard to hear. Just know what that is. Pleural friction rub is, like I said, the lining of the lung, and it does sound like kind of like pieces of leather being rubbed together, okay? Wheezing, we know, think of wheezes as high-pitched musical squeaking sounds. Then we have something called bronchi. Don't worry about these two words. We have bronchi, which are more of a low-pitched sound, okay? Stridor, you're going to only hear very occasionally. Stridor, we usually hear in children who have an obstruction, like they've ingested, like they've swallowed their G.I. Joe, or they have a hot dog stuck in their airway, or have you guys heard of RSV? Mm-hmm. So RSV is that virus that kids get, and it shuts off their airways sometimes. So stridor is only heard in this area over the trachea. It can be in adults, but often in kids, and it usually either means obstruction or they have some type of respiratory distress going on.
So like
and it sounds like it's like a screaming noise.
would you have that too when you have like an allergic reaction?
You may have that, or you might have some wheezes. So you can only call it stridor if you hear it here. If you hear it down here, they turn into wheezes. Okay? Okay. So when somebody is short of breath, which dyspnea is just another word for shortness of breath, okay? When somebody has dyspnea, we're always like, well, it's something in their lungs, but there are other conditions that it can be. So somebody who's having an arrhythmia, if they have heart failure and they're backing up fluid into their lung, they have inflamed heart, then you can have cardiac shortness of breath. If somebody has aspiration, and I would also add here acid reflux. I don't know if anyone's had acid reflux so bad that it spills into their lungs and causes them to cough, but that is a very real thing. Neuromuscular, like if somebody has like Lou Gehrig's disease or some type of where the brain stops telling the lungs to breathe. And then psychological, this is a huge reason for shortness of breath. I mean, if any of you have ever had an anxiety attack and you're like, I can't breathe, right. If you don't know it's anxiety, you might think that you're having like a heart attack or something. So this is a really popular reason for ER admissions with shortness of breath and anxiety. Of course, you have to work them up, but oftentimes, and you guys can all relate, that oftentimes it's anxiety. Okay. Again, none of this is going to be on your checkoff except for when you do the 99. But 99, the way you're doing it, tactile means touch, right? So it's touching. These are sounds that you hear while you're listening through a stethoscope. And even though I disagree with it, there are some questions on your quiz about bronchophony, egophony, and then this whispered prectoriloquy. So just remember, for bronchophony, you say 99. Egophony, they say E, okay? It's not a technique that you guys are probably going to use very much, so I don't like how much emphasis they put on it, but nevertheless, it's there. The whole purpose of these voice sounds, the whole reason we do them, is if somebody, let's say somebody has a right-sided pneumonia. When I put my stethoscope over this, I should be able to very clearly hear what they're saying. If I go over here where there's all air, I shouldn't be able to hear what they're saying very well because it's air. The vibrations get lost in the air in the lung, okay? Does that make sense?
So if they have pneumonia or something, you will be able to hear.
So like, yeah,
You won't be able to hear them say these things.
well, it's just not clear. Like if you ever put your stethoscope and somebody's talking, you can't understand what they're saying, right? So that's normal. You shouldn't necessarily, because the voice gets lost in the air. If there's something solid for the sound to travel through, then you're going to hear them clearly say 99 or E or 1, 2, 3. So I just want you to get like why people like nurses need to know what this is, though in real life I doubt you're going to see it very much.
Okay.
So ding ding ding, quiz items. All right. So COVID, common respiratory conditions. Now we have COVID with the acute respiratory failure. Here is the atelectasis, which is our collapsed alveoli. When we say lobar pneumonia, that just means pneumonia. If pneumonia is, all over, then we say they have walking pneumonia or whatever. Lobar pneumonia just means one lobe. Acute or chronic bronchitis, emphysema and asthma. We talked about the COPD here. Pleural effusion, that's when fluid leaks into the little lining of the lung. That's not a good sign. That usually means some big infection's going on. Congestive heart failure, yes, it's the heart, but if the heart is not pumping the blood and the fluid through, where does it back up? Lungs and legs. So CHF, lungs and legs.
Why did they take the congestive out of it?
They just to call it heart failure. You might as well put congestive in there, it'd be the same thing. Most of the time you'll just hear it as CHF.
They're afraid of labels.
Right. They're afraid of labels. Somebody got offended. Pneumothorax, it just means that a part of the lung has collapsed. When you are listening over a pneumothorax, what kind of lung sounds might you hear? Yes, this is a trick question.
No air.
Right. You should have
Collapse.
absent. You should not hear inspiration. You should not hear expiration over pneumothorax. This pneumocystitis, this is a very specific infection associated with poorly controlled AIDS patients. What's a pulmonary embolism?
Blood clot?
Yes. Usually it's traveled up from the calf and it makes its way up, goes through the heart and lands in the smallest part of the lung to where it can't, go any further. This can be fatal. Yeah. It often is fatal. If they're home and they have a PE, we just call it a PE. If it's a big enough PE, they may not even make it to the ER. Sometimes they're already in the hospital and they
Do they
throw a
travel
clot.
fast?
They do well, so they travel with your normal circulation. So in a matter of 30 seconds, if a piece breaks off, it can either land here or it can land up here and cause a stroke. But if it lands in the lungs and it shuts off a big enough part, it is often fatal. And then, of course, lung cancer, which between men and women is one of the most fatal malignancies. But I don't think there's any lung cancer questions on like the quiz or anything. So that's it on these slides. Okay. Okay, so just like when we were talking about the head, we had different landmarks. So the thorax being a much bigger area, there's very specific landmarks that you're going